This is open versus endovascular treatment of ruptured aneurysms, 10-year BRAT report and overview of other trials by Michael Mooney and Spetzler. Disclosures as listed. BRAT design, randomized trial that has previously been reported, and it's an intent to treat analysis and a single center study with a follow-up period of 10 years. Methods, there were no anatomical inclusion or exclusion criteria, and 4 experienced neurosurgeons treated these patients. The goal was to treat within 24 hours and crossovers from one treatment to the other at the discretion of the attending physicians. Primary outcome was modified Rankin score at 1, 3, 6, and 10 years, and sentinel events included subarachnoid hemorrhage, retreatment, or death. The all-inclusiveness of BRAT as patients were randomized when they entered the emergency room allowed the inclusion of patients that had AVMs associated with fistulas, fusiform blister dissecting, or non-aneurysmal subarachnoid hemorrhage. Saccular aneurysms represented 87% of all aneurysms submitted into the trial and are the basis of this presentation. Of the saccular aneurysms that were assigned, 356 were treated. 6 died prior to the initiation of treatment, 3 in each group. Thus, 178 were coil assigned, of which 64 were crossed over to clipping at the discretion of the endovascular surgeon. This was 36%, and 178 were clip assigned, where 1 was crossed over to coiling, less than 1%. In total, then, 241 were clipped, and 115 were coiled. Why were they crossed over? 22% were crossed over because they had associated large hematomas that required surgical evacuation. The remainder were crossed over for unfavorable anatomic criteria, either being too small or too large as perceived by the endovascular surgeon. When saccular aneurysms were evaluated as to their primary outcome of modified Rankin score of greater than 2, there was no significant statistical difference at any point. When one looked at the 10-year results, 53% of the patients that were coil assigned had a modified Rankin score greater than 2, and 51% had a modified Rankin score in those clip assigned. When one looks at the aneurysm death, they were identical or nearly identical, with 31% in the coil assigned and 33% in the clip assigned. When one looked and separated out the posterior circulation saccular aneurysm, there was a difference that favored endovascular treatment at 1 year. This difference disappeared over subsequent years, and then again was significant in 10 years. The problem with the posterior circulation was that the randomization process was not equal. Thus, a large number of patients, for example in PICA, were all assigned to surgery, with only 2 patients actually being treated with coiling. The remainder can be seen readily on this slide. If the anterior circulation, which is the cohort that was evaluated in ISAT, is reviewed, one can see that there was no difference to benefit at any time at the designated periods. So although at 10 years there is a trend toward better outcomes with clipping, when one looks at the death by assigned treatment and actual treatment, again, if anything, there is a small but statistically completely insignificant difference favoring clipping over coiling. When you look at the anatomical distribution of the anterior circulation as opposed to those in the posterior circulation, there's very good parity between the two assigned groups of clipping versus coiling. Looking at retreatments, there was a vast difference. At 10 years, almost 20% of patients requiring coiling, with less than 1% requiring repeat clipping. Aneurysm obliteration also is significantly different. At 10 years, it actually went down to 22% for coiling and was at 93% for clipping. For rebleeding and death, there were no rebleeds in those that were in the clipped cohort, even including all those that were crossed over to clipping. There were 2 documented subarachnoid hemorrhages leading to death at 8 and 9 years respectively in those that were randomized to coiling, and that reached significance. Looking at the studies that have been performed, the debate really is coiling superior? And if one reviews the slides, there's really no difference at any time point. The concerns are patient selection, durability, rebleeding, coil migration. So if one looks at ISAT at 1, 5, and 10-year follow-up, in the 2005 initial report, with the endpoint being modified Rankin score greater than 2, there was a benefit to coiling, which was significant. When this same review was done at 5 years, there was no longer a significance. When this was reviewed at 10 years, looking only at the English cohort, there was no difference in survivors, but now the endpoint was utilized as death, which favored coiling and was considered significant. When you look at rebleed rate for coil-treated aneurysms, it was significantly higher than for clipping. In ISAT, equipoise required. More than 97% were in the anterior circulation, and only a fifth of those that potential candidates were enrolled, and the vast majority, almost 80%, were grade 1 and 2. There was a difference in delay of treatment, with more than 15 hours delay for those that were clipped as opposed to being coiled. There was also no post-op documentation required for cohort patients, and despite equipoise requirement before patients were randomized, 30 patients that were randomized to clipping were not clipped. Of those, then 26 went on to coiling. Very much as in BRAT, the coiled cohort had an almost 20% retreatment requirement. For ISAT long-term follow-up, where the title suggests 18-year follow-up, but the actual report was really for 10 years, the authors state that the results of ISAT apply to those patients who were eligible for the study. In that same article, they then, toward the end, say, we think that the results apply to most patients with a ruptured cerebral aneurysm. With the improved coil devices and techniques that are now available, most ruptured cerebral aneurysms are anatomically suitable for coiling, and 85% of aneurysms in the UK are coiled. So if one looks at retreatment and death from subarachnoid hemorrhage in ISAT trial, the bottom line is that there is a significant difference where the risk of rebleeding from coiling versus clipping is 2.5 times higher, and the risk of death from rebleeding is twice as high in coiling versus clipping. The critical question of treatment effectiveness remains a concern, with recurrences being documented in multiple studies, and incomplete treatment risk is the same whether a patient is inadequately coiled or inadequately clipped. Recurrence is of a specific patient treated at an excellent endovascular center with an initial good result, and then 6 years post-coil, the aneurysm has regrown. At the time of surgery, one can see the coil mass extruding from the aneurysm. A patient from Norway, one can see the recurrence of an aneurysm after multiple coilings, a video demonstration of the aneurysm being exposed, and the goal or plan was actually to clip the basilar artery below the SCAs, but upon inspection, the aneurysm was able to be clip reconstructed. And one can see the results of the occlusion of the basilar artery aneurysm. There are other concerns with migrations. A patient developed progressive visual deficit after coiling, where the coils had migrated directly into the optic nerve. And in the case right below it, the coils had migrated into the third nerve in a neuro-ophthalmologist 3 years after stenting and coiling, causing a third nerve palsy. In the next trial, the question is raised of how many randomized trials do we need before we can accept a final result. It should be recalled that for cardiac revascularization, the first 3 trials and for the endovascular treatment for stroke trials were all negative, and it was not until subsequent trials proved the appropriateness of those treatments. At this point, when comparing coiling and clipping, the risk of treatment based on BRAT are the same, are identical: complete obliteration, retreatment, rebleeding, and death. All favor clipping. So in conclusion, there remains an open question, and the indications for a large randomized trial appear to be present. Thank you.